Word on Health, the report with its finger on the pulse of popular medicine, with Paul Pennington. Word on Health, for your very best of health.
We live in an age where technological and medical advances have changed the way many conditions are detected, treated and managed. One of the latest innovations has the potential to provide a sea change in the diagnosis and treatment of conditions related to the pituitary gland, which around 70,000 people across the UK live with. Some conditions like adrenal insufficiency and Cushing's disease are more common than others, but all pituitary conditions can have significant and lifelong impacts on patients. Professor Stafford Lightman, founder of the Pituitary Foundation, reminds us of the role that the pituitary gland plays.
Well, your pituitary gland is basically like a conductor of an orchestra of all of the hormones which are produced in your body. It's situated basically about 1.5 inches back from the bridge of your nose, just under the bottom of the brain, because it's actually regulated by the brain. And what it does is it sends messages through your bloodstream to many of your hormonal systems in the body, such as your thyroid gland or your adrenal gland or your ovaries or testes, and tells them when to be active and when not to be active. So you can think of it as a conductor of the endocrine orchestra. It conducts your hormones to give you the right level of hormones at the right time of day.
What impact can it have on a person if the pituitary gland isn't functioning as it should?
Well, there are two things. It can either function too much or it can function too little. So if it functions too little, it means your thyroid gland will stop making thyroid hormones. It means that your sex glands will stop working. So you will have a loss of testosterone in a male, loss of periods if you're a female, and it will stop regulating your adrenal glands, so you stop making cortisol. Cortisol is the one hormone in the body which is essential for life, and if you don't produce any of that, you can die. So basically, if it's under-functioning, your body systems basically slow down and effectively stop. If it creates too much, it can make too much of individual hormones which activate specific glands. If it makes too much, it can give you too much cortisol, so it can cause Cushing's disease. It can rarely give you too much thyroid hormone, giving you thyrotoxicosis, and it can give you too much growth hormone, for instance, which makes your body grow. But also if it grows too big, it can have local effects because where your pituitary gland is very close to the nerves which go from your eyes to your brain, and it can actually decrease your field of vision and eventually cause blindness. So it's critical to lots of body conditions.
What can cause the pituitary gland to stop functioning properly?
The major thing that affects the pituitary are tumours. Not malignant, nasty tumours that spread around the body, but tumours which basically causes the pituitary gland to expand. And the most common ones are ones which are not secreting any hormone itself, but it just basically pushes on the rest of the pituitary and puts the normal cells under pressure and they stop working. So a benign pituitary tumor can actually stop the normal cells making the normal hormones that it makes. These tumors, though, some of them can also be tumors of the cells that make the hormones that stimulate particular glands. So if you've got tumor of the cells that make the hormone that stimulates your adrenals, you can get Cushing's. If you have a tumor of the cells which make growth hormone, it'll give you the condition acromegaly, which is what makes too much growth hormone. So you can either have secretory tumors which cause excess hormone or non-secretory tumors which cause pressure in the pituitary and stop it making other hormones.
What are the telltale symptoms?
Probably the earliest one in women will be that they lose their periods because you need a very close regulation of your hormones to have a normal cycle. In men, they can get hypogonadism, they might get impotence. And if you produce too little cortisol, to begin with, you're just feeling under the weather. You wake up in the morning, you don't have all the go that you would normally have. You feel just generally not as well as you could. Some people, actually, their first symptoms are due to a lack of vision. So you lose your peripheral vision, the vision on either side of your head because of the pressure from the pituitary gland. And so they will present with the loss of vision. If you're secreting too much hormone, then of course, then you have the symptoms of what that hormone does. So if you're producing too too much growth hormone, then you get growth of your tissues, you get too much growth of your jaw, and you'll also get sweating and other things like that as well. If you make too much cortisol, you'll get the Cushing's disease. So you'll get a lot of fat deposited on your stomach, a lot of muscles, and things like that will happen.
Outside of a number of rare genetic disorders, I believe there are no specific groups of people more susceptible to pituitary gland problems. I read that one of the struggles people face with the conditions is delays in diagnosis. Currently, the average time to diagnosis is around 7 years. Why does it take so long?
There are two things. First of all, there is suspicion. So it is important that a doctor becomes suspicious that there might be something wrong. The difficulty with endocrine diseases is that they come on very slowly. It's not like having a heart attack. You get sudden chest pain and think, oh my God, that must be a heart attack. This comes on very, very gradually. And indeed, what tends to happen is that the people that you live with don't notice it because it comes on so slowly. So the way you are today is actually very similar to how you were a month ago or 3 months ago. The people who would tend to notice it is people who haven't seen you for a year or 2 years. They would tend to be the people who notice it. Then there's the diagnosis. Now, a lot of these hormones are secreted very dynamically, which means that the levels are very variable across the day. And unless you've got a very severe condition, so you have very high levels or very low levels, just the odd hormone test might not actually tell you the answer. And so doctors have had to create ways of trying to either stimulate or inhibit secretion of hormones. So if you're making too much hormone, what the doctors will try and do is to give you a test to see whether they can turn it off. And in a normal person, you can turn the hormones off quite easily. But in somebody who's got a tumor, for instance, it won't turn off so well. If you're not making enough hormone, we try and stimulate you to see whether your gland is capable of producing more of that hormone. The problem for that is that hormone diseases are not binary, by which I mean it's not a case of either you've got it or you haven't got it. There's a whole gradation. And there's a gradation when people have a very mild disease, which is actually quite difficult to diagnose. And that's where things often go wrong and people have to wait a long time.
And once you are diagnosed, are there clinical interventions that can help?
Yes. Basically, with most pituitary tumours, what you want to do is to get rid of the cause of the disease. So neurosurgery to remove the tumour from your pituitary is what you want to do, because if you can get rid of the cause, then hopefully the rest of the pituitary will make up most of its function and you'll get back to normal. But it depends where the tumour has spread and the shape of the tumour, whether or not it is amenable to surgery. If you can't operate on it, you could do two other things. You can either give them medication, which might control the amount of hormone it's making. You could give them radiotherapy, which basically would shrink down the tumour cells in the tumours in the pituitary. So those are other things that you can do. But the aim, if possible, is to remove the cause.
What are the challenges with the treatment regime?
The challenges are, one, to successfully remove the tumour and leave the rest of the pituitary intact. That's the challenge. The other challenge is once you've done the treatment, there's often the remaining pituitary isn't functioning as well as it should. And it's giving back the right pattern of hormones. As I said to you, the pattern of hormones secreted by the pituitary is dynamic and changes across the day. And it is very difficult for us to give back the normal physiological pattern of hormones across the day, which normal people will have. So that's been really quite a challenge.
Professor Lightman, you're behind the development of a wearable device to monitor levels of hormones in the body for pituitary patients. How will that help in future?
Well, we have developed a system called Urhythm, and it is basically a system that you can strap on around your abdomen. You go home, you come back 24 hours later, we take it off, and we will have a sample every 20 minutes throughout the 24 hours. So we will be able to look at the pattern of your hormones over a full 24 hours. This gives us a much better way of diagnosing conditions because we're not looking at one single point in time. We're looking at the pattern across the whole day. And most hormones go very low at night and start coming up in the morning. And we can look if there's any change in regulation. The sort of things that happens is that they don't drop as low at night as they should do. And of course, you can't normally take blood samples at 3 o'clock in the morning, so you wouldn't even know this. So it's giving us a much finer way to make a diagnosis at a much earlier time. As well as this, what it does, it gives us the opportunity to tailor our treatment regime. Because now when we're giving your hormones back, we can measure whether or not we're giving it back to you in the right normal physiological pattern across the day. I think the really important point to make is that every patient is different. And if I give the same pattern of hormones to 10 different people, their blood levels will be different. And so we need to tailor what every patient gets in terms of their individual response, which is what we should be doing. It's not a case of one treatment regime fits all, because it clearly doesn't.
Where are you at in terms of its development, and when can we see it widely available?
It is available in research use only, so that any clinician who wants to use it is able to obtain it, so long as the studies he does with the patients are labelled as a research study. We've published the data from several hundred patients. Once we have a few more studies published, preferably by other people as well, then it should be available for clinics without a research use.
My grateful thanks to Professor Lightman. To find out more, visit our website, wordonhealth.com. That's wordonhealth.com.
Word on Health, for your very best of health.
Well over 100,000 people have signed up to a petition as part of a campaign by the Daily Mirror calling for an overhaul of NHS dentistry. Simultaneously, the Cleft Lip and Palate Association, otherwise known as CLAPA, has launched an initiative to end the cleft dental crisis that people born with a cleft lip and or palate face. The charity's CEO is Claire Cunniffe. Claire, for listeners who may not be familiar, could you start by explaining what cleft lip and or palate problems are?
It's the most common craniofacial condition that babies can be born with. What happens is in early pregnancy, the different parts of the baby's face develop separately. So they develop from the outside in and then they join together. And then if some parts don't join completely, that is when a cleft occurs. That can be the lip or the palate or both.
What's the prevalence of babies born with a cleft lip and or palate problem?
It's around 1 in 700 babies. That's about 1,200 babies a year, which is 3 a day, which is more common than I think most people realise. Around 45% will be isolated cleft palate, 24% will have isolated cleft lip, and then 31% will have cleft lip and palate. And there's different types of cleft lip and palate. There's unilateral cleft lip and palate, which is one side, and then bilateral cleft lip and palate, where cleft is on both sides of the lip. That's the least common type, but is the type that's going to probably have the most surgery and kind of speech implications.
Do we know why babies are born with cleft lip and or palate problems?
There's no single cause. The research that does exist suggests that it's a combination of genetic and environmental factors. But because there's so many factors involved, it can be really difficult. So if you were born with a cleft, your chances of having a child with a cleft are increased, and people who are born with a cleft who are planning a family can have genetic testing to see if they're likely to have a child with a cleft. But there's not really anything that somebody can do in terms of preventing a cleft from happening, because there's so many different factors involved and there's still little that's understood about why it happens.
How does being born with a cleft lip and or palate affect a person's dental health?
Cleft affects the way that not just the lip or the palate is formed, it affects the whole mouth. So it affects the mouth, the teeth and the jaw development. This can cause teeth to be misaligned. It can cause missing teeth or extra teeth. The enamel for somebody's teeth born with a cleft isn't as strong as somebody's who's not born with a cleft. And also their gum health can be less healthy. And even after somebody's had surgery for their cleft, they often need long-term orthodontic care. Cleft is a lifelong condition, which I think is something that people don't realise. There's a need for orthodontic care, restorative dentistry, and then very specialist dental care. And that's throughout childhood and adulthood. It is that lifelong access to NHS dental care that's so critical. It's not not just the dental care in childhood. And often we find that's where the care falls away.
As I said in my introduction, you've launched a campaign to highlight the Cleft Dental Crisis. What exactly do you mean by that?
We carried out a national survey because we'd been hearing from the community that people were really struggling to access a dentist. What we found from the survey was that 49% of respondents faced issues accessing local NHS dental care. 42% said that their dentists lacked understanding of cleft-related issues. The anatomy of somebody's mouth will be quite different if they're born with a cleft. So often dentists have had quite limited training and they don't know how to treat somebody. A lot of the time they will refuse patients because they don't have confidence in treating someone with a cleft. And a lot of the time people were being signposted to private treatment. 38% said they couldn't afford treatment. We're finding that it's not just a few isolated cases. This is a systemic problem and the situation seems to be getting worse rather than better.
What are you calling for?
We want to see a really clear commitment across all 4 nations that no one is refused NHS dental care purely because they were born with a cleft. We also want to make sure that dentists receive cleft-specific training as part of their dental education, but also continual professional development. We want better communication between the cleft teams and the general dentists. Ultimately, we want to make sure that everybody born with a cleft, whether they're a child or an adult, receives the adequate dental care that they need.
My grateful thanks to Claire Cunniffe. To find out more and connect through to the Cleft Lip and Palate Association, visit our website, wordonhealth.com. That's wordonhealth.com.
Word on Health. On air and online 52 weeks of the year with Paul Pennington. Word on Health. Your personal prescription for your very best of health.